So what we've come to now is a very major question with multiple drugs approved. What's appropriate for first line? Is it ipilimumab? Is it anti-PD-1? Where do we go with first line? Dr. Joseph.
Sure. So this is obviously a very controversial and hot topic, and to give without any data to give any answer, really. I mean, there's no prospective data to guide us to say we should start with this, followed by this, followed by that. So we have no idea. The only thing we do know is that patients have been treated in the front line with all of these drugs, and they have done well with all of these drugs. So I think right now, at least for me, they all should possibly be an option and individualized to the patient.
Do you agree with that, Dr. Kaufman?
Well, as much as I think we would all like to consider giving, the anti-PD-1s in first line, the clinical trials that have been published so far really were using these agents in second line. And so right now, I think that it would be a little bit premature to use PD-1 in first line. I think we might see...
Let me just counterpoint that, though. I mean, the Nivo versus dacarbazine in Europe is published in the New England last month, and that was an overall survival advantage in the front line. So we have that data.
But not based on what we now here consider to be...
No, it wasn't versus IPI or wasn't versus... But if we want to wait that long, that's fine. But
we don't have to wait that long. So as we talk today, all of the first line studies have been accrued. The first line ipilimumab versus pembrolizumab,
right.
The ipilimumab versus ipi-nivo versus nivolumab have been accrued. And while some of those patients who were on the initial pembrolizumab trials were first line, I would say that the FDA approved these drugs based on the response rates and durability of response, not on their overall survivals at this point. Whereas the other drugs have been approved based on known survival advantage, and at a time where we now have 10-year survival advantage with ipilimumab therapy just published in JCO.
Yeah, I think we're going to get this data, over time, and it could very well be that PD-1 will become, in fact, the first-line therapy, but I think still at this point it would be a little premature to use it. And again, I think we do have other agents that are available, and both ipilimumab and interleukin-2 have been associated with, durable, complete responses, and I think these are actually agents that are quite valuable.
Well, and I think another question too, at least in my mind, is does sequencing matter? If you give someone a PD-1 agent prior to giving them immunotherapy, do they do better? Do they do worse? Does it impact the durability of the response if you give IPI first and then PD-1? Again, we're not talking about the combination given together, but the actual sequencing if you're not one of those patients who can tolerate both of the agents given together, and I think we don't know the answer to that.
I think it's also important to also recognize that at the moment, the PD-1s are not approved in a first-line setting. They are approved in patients who failed prior ipilimumab patients. So I think that's also important to recognize as well as we think about this for our patients at the moment.
And as we're all here doing clinical trials, I tell my patients who are looking for first-line PD-1, PD-L1 therapy to enroll in a clinical trial.